Today's chair is Dr. Gillian Lowe, who is a consultant haematologist based in Birmingham and specialising in haemostasis and thrombosis, and who has a specialist interest in problems with bleeding and thrombosis. So without any further delay, I'll pass over to Gillian. Thank you.
Thanks, Jo. Can I just check you can hear me okay?
I can, yes.
Okay, that's great. And sorry, everybody, for the slight delay in the start. So as Jo said, my name's Jill Lowe. I'm a haematology consultant in Birmingham, and I specialise in haemostasis. And we're going to run this session, which is really designed to be about sort of everyday practical anticoagulation issues. So joining me is my colleague Will Lester, who's another consultant haematologist in our team, and Sarah Lockett, who's an anticoagulant clinical nurse specialist. And we're going to present a few cases and give you what we believe is a clinical nurse specialist perspective, and then comments from me and Will. And it would be really good to get lots of discussion going. We know this is the last session, that people are probably a bit jaded. It's Friday afternoon. We've tried to make it not too PowerPoint heavy, so please do contribute. If you want to type on chat, that's fine. We'll look at your comments and try and address them. So I'm going to pass over to Sarah to talk through the first case, which is someone who she's very heavily supported, and then we'll go through comments about that towards the end. So thanks very much, Sarah, if you want to go through your first case with us. Thank you.
Thanks, Jill. So I'm going to talk about treating a patient with cancer-associated thrombosis. So as you can see from the first slide, this 62-year-old male had a new diagnosis of PE, cancer-associated. His malignant tumour of the large intestines with the creation of a defunctioning colostomy. So he declined his 6th and final dose of chemotherapy due to his side effects of lethargy and nausea, basically saying that he hadn't got time to sit around and waste his life doing this. He felt so poorly from the chemotherapy, it wasn't worth carrying on. So prior to discharge, he was commenced on enoxaparin 1.5 milligrams per kilo once daily, and waiting an appointment in our nurse-led VTE clinic due to his recent PE. And we have a KPI to be seen within 4 weeks. So next slide, please. These are just a list of his coexisting medical conditions, as you can see, and for all of these, he was taking oral medications. Next slide, please. So 10 to 4 on a Friday afternoon, as always, I received a call saying that the patient believes that he has an allergic reaction to enoxaparin and had stopped his treatment for 2 days. And he stated that he was having 17 episodes of loose stools that day, and this had been ongoing since commencing enoxaparin. So he stopped his treatment for the 2 days, and the bowel movement settled. He advised the oncology team, and they, as you can see, advised that he restart the enoxaparin due to this being a new clot and requiring treatment. So I discussed this with the consultant haematologist that was with me at that time, and she advised that we switch to the fondaparinux 7.5 milligrams once daily. Obviously, I provided safety netting advice to ensure that the patient was safe, and would follow up in 2 weeks unless there were any other issues, and he obviously knew how to contact us. So when I did do the 2-week follow-up call, the patient complained of blurred vision, dizziness, and that he was unable to see the television and feeling generally unwell. Our usual advice, as per our safety netting, is to call 999. My concern was that he was having a cerebral bleed of some sort. He felt too unwell, so I made the call for him, and he came into our ED at this hospital here. Eventually, I found out that his scan was NAD, and the diagnosis, as you see, was pneumonia and a low HB. Next slide, please. So he was discharged again on the fondaparinux, and then over a couple of weeks, things were going okay. He was absolutely fine, and then we had a national shortage, and so we were having to ensure week by week that he had a supply of the injections. So he was having very regular reviews and huge discussions, which was absolutely fine because that's what we're there for. So eventually, after a further few weeks, he'd sort of passed the initial phase, the first 3 months, and we discussed with the consultant. We agreed to switch to apixaban. So his stoma output had settled, occasionally a little erratic, but he was still taking his oral medications for other conditions, and he appeared to be absorbing medication. There was nothing that he could see in his stoma output, so we accepted that he would be all right on the apixaban. So the patient was happy to switch, so I counselled, offered safety netting advice, and arranged a 2-week follow-up call. So the follow-up with the patient, and he reported severe abdo pain and constipation. He hadn't sought any medical advice while he was away, excuse me, but despite the fact that I had told him or asked him to return all of his injections to the pharmacy when he collected his apixaban, he didn't. And he decided that he would keep them for safety reasons himself, and he took them away with him on holiday. He stopped the apixaban when he perceived that to be the problem, and resumed use of fondaparinux, of which he only had 3 days supply, and then he switched himself back to enoxaparin. So he acknowledged that he knew he shouldn't have done this, and obviously just said he didn't know what else to do, and it didn't occur to him to attend the local ED. So, complaining of intermittent loose stools, from what he described to me, I wondered whether it was overflow, and that he'd got pain in the right shoulder, and he had started self-medicating with laxatives, quite large quantities of liquid senna and lactulose. So next slide, please. So he now believes that the apixaban is causing the fluctuation in his bowel habits, but he's now reluctant to return to administering the low molecular weight heparin. His appetite was reduced, ad hoc small meals, so nothing substantial. So obviously I was reluctant to prescribe rivaroxaban due to that reduced oral intake. And he agreed to try edoxaban and made contact with me a few days later, stating that he has abdominal distension in the evening following his dose of edoxaban, and complained of bloating and high blood pressure, which he was checking himself, telling me that he was pacing the room. I think that probably wasn't helping his blood pressure, causing him quite considerable amount of stress. So I asked him to switch his edoxaban and tried taking it earlier in the morning. Next slide, please. So we had a frank and measured conversation, obviously sensitive, regarding the possible progression of his disease. And he did admit that these were his thoughts, but he hadn't got time to come to ED. Life's too short. So I encouraged him to present an ED and use his red card system provided by the oncology team, but he declined. And whilst acknowledging his prognosis, he states again that he's got no time to waste sitting in ED, he just needs to keep himself occupied. So again, I reiterated the advice. We talked about moving that dose of edoxaban to the morning and see how he felt overnight. So this was the weekend. He contacted me again on Monday to advise me that he had attended ED, as he appeared to be bleeding from his stoma. So the alarm bells start ringing for me straight away. But on examination in ED, it was proven to be excoriation of the skin around the stoma. However, the scan revealed progression of his disease, which is what we obviously thought, but he had no bleeding issues identified. So he was referred back to the oncology team, and they booked him for a PICC line insertion to commence palliative chemotherapy. So he admitted to me that he was feeling really low in mood, but he refused input from the Macmillan nurse that had contacted him the week previous, because he believes that others have a greater need than he does. I encouraged him to contact her and offered to make contact on the patient's behalf, but he declined. Next slide, please. So further, I then received a call from the GP later in the week, The patient had requested that I discuss recent events with the GP, and the GP had no access to recent blood results and was concerned about the low HB, which obviously I advised was a couple of months previous, and obviously informed her of the improved results. And she had no concerns there, but we did have a discussion surrounding the need for him to constantly contact the service, which was not a problem for us. It's just that we realised that he needed more specialist input, and that was from the Macmillan team. So the GP was aware of his refusal. She had spoken to him on occasions about this, and she was going to arrange a face-to-face consultation with him and discuss and encourage him to do the rest, to contact the Macmillan nurses again. And she also advised me that she was happy to continue prescribing edoxaban as the patient was palliative. So since then, he has continued with his chemotherapy. He contacted the service to say that he was really expressing his gratitude for the time that we spent explaining, discussing, reassuring him that he felt very supported, where on numerous occasions, whilst as an inpatient he didn't feel that, but obviously we were able as CNSs to be able to give him the extra time that he required. And I think that for us, we all know is part of our role, a really important part, along with all the other things that we do, the prescribing, the clinical assessments, etc. And that he was pleased that we were confident and knowledgeable. So that obviously was good for us. I spoke to this patient yesterday. He's doing quite well with his chemo. He's sticking with it. He was going away on holiday today for a few days, but his most recent admission to ED had resulted in him being switched back to apixaban. And that's the end of my case today.
Thanks very much, Sarah. There's lots to think about there, isn't there?
Yeah.
So we'll just wait and see if any questions come through. Again, feel free to contribute any points or questions you've got. I'll start by asking for comments on a few things. So I think the thing that struck me really is how our involvement as medics is really the tip of the iceberg, and we might make an initial recommendation about what somebody should have, but these ongoing contacts are absolutely vital. And had he not had that level of support, he may have stopped anticoagulation and had a further event or come to some harm. So I think the first thing is us acknowledging that both aspects of this MDT input are equally as important in keeping patients safe. Will, I don't know if you want to comment on approaches to patients who've got stomas or perhaps reduced GI transit time, and what we do with anticoagulation and them, just as a discussion point to kick off.
No, sure. I mean, I think unless someone's got total intestinal failure, in which case it's highly unlikely they're going to absorb a drug. Well, saying that, they'll often absorb some warfarin, but I think it's more tricky with DOACs if you've got complete intestinal failure, if you're on TPN. But short of that, I mean, generally speaking, we'll often check drug levels, but they're usually okay. I mean, I don't know if you agree with that.
Yeah, I think that's right. I think use of levels for somebody who you expect to have some absorption is quite helpful. And obviously for most patients it is extremely helpful if they can take an oral agent. So as you say, it's worth a go for people who are felt to have some enteral function.
I mean, there were a couple of issues from this case that come to mind. One is that from a patient perspective, often a lot of patients will say it's really hard to get hold of healthcare professionals. And that to be able to communicate with anyone within the trust is really tricky. And in this case, this gentleman, I think, really felt that that the anticoagulant team were the main source of communication and care, which suggests that you've perhaps provided a level of access that isn't provided by anyone else. I don't know if you'd agree with that, Sarah.
Yes,
which puts quite a lot of burden on you, really.
Yeah, definitely. 10 consultations I think I had in total with this gentleman, which is really for us maybe 2 or 3 So it was quite intense. Yeah.
I mean, if historically, if the anticoagulant team was seen as a warfarin dosing service, you know, none of this would be happening. But it's, to me, it seems it's almost beyond the extended role of a very highly qualified non-medical prescriber like yourself, who is independently reviewing patients. I mean, it's an evolution to me from what would have been, say, 20 years ago, where if it wasn't anything to do with your INR, then, you know, although it's always been the case that when people came for their INRs, they would tell you about all their other problems. So I think anticoagulant clinics have always fielded a lot of other issues, and I suppose it's a really difficult call as to say what's the limitation of what we can do. And you signposted this person every time to the right place, and so that was the. But I'd be curious to know whether anyone who's listening sort of feels the same about their anticoagulant service being a point of contact for patients' issues that maybe go well beyond anticoagulation. And my other question, actually, to people that are listening is, so our colleague Charles Percy, who came over from Wales, often says, "Oh, you know, patients in West Midlands seem to be very intolerant of medications," and it is some patients don't seem to feel that they tolerate any form of anticoagulation, and you end up cycling through one after another, and you know in your heart of hearts it may not be anything to do with that anticoagulant, but if someone strongly believes that they are getting side effects, it's very difficult to deconstruct that. So you end up switching and swapping. And again, I'd be interested to know what people's experience are on that as well.
Yeah, can I just add as well, Will, that this gentleman remains convinced that it is the anticoagulant that's doing this to him, despite the fact that he knows that he's palliative and his cancer is progressing. He still believes it's the anticoag medication, sadly. And just to say that it has been a real privilege, really, to support him. So.
Is this a West Midlands problem? Are our patients particularly intolerant of medications, or is Charles right? Is it a local?
Yeah, that was going to be my other point, actually, about, you know, these are commonly prescribed medications that are often associated with symptoms, and, you know, it's not dismissing somebody who thinks they have side effects, but equally not, you know, sort of changing if not needed. And I agree, it would be really interesting to see if anyone else has got any comments about how you approach a patient who starts an anticoagulant and then develops what you think is an unrelated symptom, but they are concerned about. I think really, you know, all you can do is say to them, we're not sure this is related, but if you feel it's going to stop you being able to take it, then we can think about an alternative. The worry is the patients where you then quite quickly cycle through lots of anticoagulants and are starting to run out of options. I don't know if different regions have different tolerance rates. That sounds like a sort of good national audit study, doesn't it? See how compliance changes.
I mean, one of the problems with, say, most of the DOACs, so Rivaroxaban, Apixaban, and Podoxaban, all have shared excipients. So I suppose in theory, you could, if you're not allergic to the drug itself, but whatever's in the actual tablet, you know, all sorts of things like maize starch and other things, then we have tried dabigatran, because that is a capsule that has no shared excipients with the other three. I have occasionally switched someone from oral to heparin, purely to see whether whatever those symptoms are just resolve, because again, heparin shouldn't have any cross reactivity with anything else. I think Sarah's got a hand up.
Yeah, just wanted to say that the latest attendance in ED he was actually offered dabigatran, and he wouldn't go near it. He went back to the Apixaban because he knew the name, so he was just familiar with it and he didn't want to try another one. So.
Okay, I don't think I've got anything else to specifically mention about that case, and I can't see any messages coming through. Let me just check once more. So providing, Joe, you're not seeing any other questions, we'll move on and discuss the other cases, which are much briefer. So for these cases, I'm going to present them and then we'll have a discussion around them. These are hypothetical cases, but I'm sure we'll all sort of recognise things that we see all the time. So the second case example is about a 26-year-old woman who's 39 weeks pregnant, so very close to date of delivery. who presents with a swollen and painful left leg and is then found to have a proximal DVT on ultrasound Doppler. And this lady's in her first pregnancy with no past medical history, and when she is asked, says that she's intending to breastfeed, and she has no personal or family history of thrombosis. So if we just pause at this point and have a panel discussion and contribution from the audience about what sorts of things you'd be thinking about. So Sarah, if we want to start with you, if you were counselling this lady about anticoagulation, what would be the things that you'd anticipate her asking you, and what do you think would be your main initial concerns?
For the sorry, can you just repeat? There was a noise in the background. I'm in an office. Say it again. Sorry, Jill.
We're just talking about the case example of the pregnant lady with the DVT very close to term, and what you think from a CNS perspective the main concerns would be counselling a pregnant woman about anticoagulation, what questions a patient would frequently ask you, and what you would be thinking about in this sort of consultation.
Obviously, if she's still, what we find with the enoxaparin injections, if that's what she's using, she will be, often they're concerned about injecting into the abdomen. They're frightened that they're going to injure the baby, so we'd be giving alternative injection sites advice, always safety netting bleeding, spontaneous bleeding and bruising, and also as regards the breastfeeding post-natally, obviously we wouldn't be wanting them to be breastfeeding, so that warfarin is the option, I believe, or am I right? Please jump in. Is that right?
Yeah, that's right. So I think it's more
at our site we don't deal with them very often. Yeah, pregnant ladies, but we would be going for warfarin, obviously, because they can't breastfeed with the Pixaban and with the DOACs.
That's right. So it's more thinking about, you know, what the woman's wish is in terms of whether she would want to breastfeed or whether she's decided or not, because that has implications on the anticoagulant we choose. So I agree with you. The common questions that patients will often ask, and pretty much the first question normally is the treatment harmful for the baby? And then often concerns about injection technique, and subcut injections into the abdomen, even, you know, at term, will not cause any harm to the baby, but obviously women do need reassurance about that. I guess the other issue which I'll ask Will to comment on is about women presenting very close to delivery with a new DVT, and whether it's enough to anticoagulate them, and what the role of IVC filters is, which is something that we talk about reasonably frequently and comes with pros and cons. So I don't know if you want to talk about that for a minute, Will.
Yeah, I mean, this is a nightmare scenario because we know that this delivery is going to be imminent, and we know that if we've only given a couple of days of anticoagulation, then have to pause it for the delivery, then there's a, you know, that risk of getting a pulmonary embolism. And so, I mean, if this person needed surgery, we'd definitely put in a filter if it was within 4 weeks of the event. But this is different. This is delivery, and it technically is really difficult to put in an IVC filter in a person at the late stage of pregnancy, because the gravid uterus pushes right onto the IVC, right up to the renal veins. The IVC is dilated. It's technically really difficult, and there's a much higher risk of it going wrong and the filter migrating into the heart. And you know, we've had negative experiences before, haven't we, Jill, with hematomas from the IVC. So I personally am really not keen on them, but I guess it's something to be considered. And what you'd really want is ideally for this delivery to be as long as possible after the initiation of treatment as you can make it. So, you know, if they can go over dates, which is not something anyone has any control over, that would be good. I'm not a great believer in inducing people, because I don't think that really gives you any control over what's going on at all. So yeah, I think we'd start treatment, and you'd have to have a careful think about whether to put in a filter or not. I mean, about the subject of giving heparin injections, it is a very common question, isn't it? About, I can't do it in my stomach because I'll stab my baby. But the needle you need for to get anywhere near the baby is going to be, you know, that long. So it's not an issue. I think it just needs reassurance, doesn't it?
Yeah. So we've got. Sorry, I think, did you have another comment, Sarah?
Sorry, I was just going to jump in about the breastfeeding afterwards as well, that we do have patients that are coming in to the warfarin clinic, and we try to switch them to the DOACs, and even though we would, you know, suggest that, well, they're not breastfeeding really, but they're still trying, even though they're beyond that, they're still, because it makes them feel like a mother. That's often the sort of comments that we get, is that they still keep wanting to try, even though they're expressing very little milk, they still want to keep trying. So,
yeah,
quite emotive, really. It's quite an emotive issue for them.
Definitely, and I think, you know, asking these questions about intentions has to be done in a totally non-judgmental way, doesn't it? Because it can sort of be a difficult area to discuss, especially if it was a woman not in her first pregnancy who's had difficult experiences before. So we've got a couple of questions that have come in on this, which is great. So the first one is on the Q&A and asks what the risk of bleeding is if this lady goes into labour. So we would typically start usually with twice daily treatment dose enoxaparin in women with a new clot in pregnancy. And that risk of bleeding all depends on the timing from the last dose of Clexane until the woman's in active labour. So I think there is an increased bleeding risk compared to baseline, but we would generally advise women that as soon as they think they're in labour, they omit their next enoxaparin injection. And generally, if you're over 6 hours, certainly over 12 hours between that time point and being in active labour, the increased bleeding risk is minimal. If it's within that time frame, there would be a risk that everybody would need to be aware of, and we'd need to sort of do things like, you know, make sure the woman's got a cannula, has fluids, has prompt treatment to contract the uterus after delivery, and those sorts of generic measures. But that would be our approach. I don't know if Will or Sarah have got any more comments on that question.
Yeah, I mean, it's a good question. I think often, you know, if you start therapeutic anticoagulation on someone at this stage, you know, that they may well be concerned about bleeding, and their worry may well be that they're going to get an immediate uncontrollable hemorrhage. But actually, we don't tend to see that. Even if you've been given therapeutic heparin and you deliver, you know, within, say, 12 or 16 hours of therapeutic heparin, you're still anticoagulated. What we tend to see more commonly is delayed PPH and wound hematomas, because I think the quality of the clot you form is less good because there's anticoagulant on board. And so you can often achieve some degree of primary hemostasis. You don't necessarily have an immediate hemorrhage, but it's the higher risk of delayed hemorrhage, I think. So it's certainly, if someone had therapeutic heparin within 16 hours of delivering, you need to be pretty vigilant afterwards about delayed bleeding. And you've obviously got to get the anaesthetist to review them as well, because they may well have been wanting to have a spinal for an anaesthetic for a cesarean or for pain relief. And it makes it much more tricky because you have to have that 24-hour off time before you can do that. So we need to make sure people realize they can still have good pain relief with remifentanil, PCI, etc. So the anaesthetist definitely come into play here. And I see there's another question come out. If you want to handle that, Jill.
There's a comment in the chat we'll do first, and we'll go back to the other questions. So the chat comment is that this individual said that they would keep their ladies on split dose low molecular weight heparin in the first few weeks postpartum. I agree with that. I think that's quite common practice. So we would usually put people back on low molecular weight heparin in the postnatal period, sometimes on once daily because of the fact that renal clearance is not as quick as it is in pregnancy, but it does depend a bit on the individual woman and the timing of when the DVT or PE was diagnosed. But yes, the principle of going back on low molecular weight heparin for the first couple of weeks while bleeding settles and the woman recovers from the delivery, and then changing to an oral anticoagulant, whether that's warfarin or a DOAC if they want to, typically around 2 weeks postpartum, I think is quite sort of accepted and unified practice, and I would agree with that. So if we go on to the other question, which is...
Actually, Jill, can I just ask a question, see if anyone responds to this?
Yeah.
We don't tend to use unfractionated heparin. partly because people are so awful at it, and obs and gynae even worse than everyone else, and everyone's bad already. So you can't. And so we tend not to use it because it's done so badly. But I'd be curious. Often, if you read someone's How I Treat, or there was something in the BMJ about how to manage pregnancy VTE, and I did, you know, it just was so alien to me because they were talking about using loads of IV heparin. I don't know whether people are doing that, what their experience is, before we move on to that Fonda-Parnot's question. Or we could do the Fonda-Parnot's question while people maybe consider that.
Yeah, let's do that. So if we go on to that, so the question is Fonda-Parnot's an option? So I'll speak briefly on that and then ask Will for Will's comments or any others. So it is an option, but the issue is that it's got a much longer half-life. So it's harder to manage around the time of delivery because we would typically stop it for longer than low molecular weight heparin in women who are established on it for another reason earlier in pregnancy. And the other thing is that it has theoretically got the ability to cross the placenta. So that's another thing to factor in. So I have to say I wouldn't use it in this situation unless I was really stuck and there was no way of using low molecular weight, you know, standard low molecular weight heparin otherwise. I don't know if what you think about that, Will.
Yeah, I mean, unless they point blank refused heparin, standard heparin, then yeah, its long half-life would mean there's no way you're going to get a regional anesthetic in, and you're also going to have probably you know, there's not enough data on this, but you may well have a higher risk of PPH because you'll be more likely to be anticoagulated at the point of delivery. And you definitely don't want to stop it a long time before delivery either, because this patient's had an acute VTE. So I think that whatever's got the shortest half-life, but in my opinion, not on fractionated heparin for us, because I just don't think it works well. Other people may have a different experience.
Okay, so if we just move on to the next slide, which was just my summary.
Jill, sorry.
Yeah.
Can I just interject as well, talking about contraception? That's something else that we do broach with the patients, obviously advising them that they advise us immediately, or that they don't achieve pregnancy, basically, especially on the DOACs, but to advise us immediately if they think that they are pregnant, and we can take action for them.
Yeah, absolutely. So if we go on to the next slide, that's actually one of the things that I'd listed on there in terms of the wider implications. So we've already talked about immediate management and plans for delivery. And then we would talk about contraception, both in terms of not getting pregnant on DOACs, and also the avoidance of estrogen-containing contraception in the future for women who've had a pregnancy-associated DVT or PE. So that's, and then should they become pregnant, as Sarah said, the need for thromboprophylaxis from the point of a positive pregnancy test. And then the final thing that I thought would be about postnatal management and investigations, we would consider testing for APS in a pregnant woman who's had a DVT or PE. So that, and the logic for that is that if a woman's got antiphospholipid syndrome in future pregnancies, we might consider aspirin as well as low molecular weight heparin prophylaxis. But again, that does depend a bit on what other provoking factors have been present, and the woman's previous obstetric history. In this example, it's the first pregnancy, so you wouldn't get any further information on that. But we wouldn't typically do any additional thrombophilia testing. The only thing that we would think about, because it may affect clinical management, is testing for antiphospholipid syndrome once the woman's come off anticoagulation postpartum, and we would typically give that for 3 months postpartum. So I'll just pause there. There was no more on this case on my slides. I don't know if anybody's got any other comments they'd like to make just while we're finishing off thinking about this case.
Well, that's quite an interesting comment from John.
Yeah. So that, just in case anyone can't see, there's a comment come through that says tinzaparin has been approved by a fatwa if refusal of heparin use is due to religious reasons, which is interesting. And my experience of that has been that if women are asking about use of low molecular weight heparins because of porcine origin and there's religious issues, generally, if it's felt to be necessary for the woman's medical care, then that's felt to be acceptable. So I've had that discussion a lot where patients have then said, oh, you know, I've been advised that it's okay to have it if I need it for my health. But I think that's useful to know about that particular product. And if anyone's got any similar experience and having that discussion about porcine origin products, it would be helpful to share that. Okay, right, we'll move on to the last one. Okay, so this is again another example just to get some discussion going, hypothetical example. So a 58-year-old man with renal cancer who comes in with a GI bleed with significant requirement for resuscitation and need for stay on ITU, and is found to have varices on endoscopy. And then 2 days later, during the ITU admission, is diagnosed with a new right-sided proximal DVT. He's got active cancer and is due to have his next treatment line considered with the oncologists. So the issue to discuss here is the management of a patient who's got a new acute thrombosis but has a very high bleeding risk, and how we can manage this well by communicating between teams, between different medical teams to facilitate management. So Will, I don't know if you want to talk generally about that, and then we'll see what discussion points come up.
Yeah, I mean, I think I'd initially go for low molecular heparin. And I think if there's been a very recent bleed, one might consider giving a reduced dose rather than a full therapeutic dose initially. There's a little bit of data from an observational multi-center study, which was actually to do with patients with thrombocytopenia, you know, levels anything below 100. And they did show that those patients given low molecular heparin at lower doses seem to do okay. So I think I'd probably be thinking about maybe an intermediate dose. Yeah, someone's put unfractionated heparin. I mean, again, it's one of those things where do you think that the medical team will be able to manage unfractionated heparin well? And I mean, you can switch it off pretty quickly, but it's just the hassle factor of you got to keep the patient as an inpatient. You've got to have them hooked up to a drip. You've got to make sure you measure their levels, and it's not that difficult to over anticoagulate people, and that obviously is not desirable, but I understand why people would do that. It's just that my personal experience has always been quite negative. So I'd probably go for something, maybe an intermediate dose of heparin as a toe in the water and just see how they got on. I wouldn't just put in a filter at this stage, because the filter, this person's probably got quite a painful leg. And if you put in a filter, that painful leg is just going to probably just get worse and more painful and unpleasant, and potentially clot off the filter and then cause DVT down the other leg as well. So I'd really be reluctant to go for a filter on its own, unless this person then kept rebleeding and it was impossible to anticoagulate them. Then I guess you would think about it, but I wouldn't be keen. I'd try and give them as much anticoagulation as they could tolerate, essentially, and it would initially be heparin, low molecular heparin.
Okay, and Sarah, from a CNS perspective, the thing that I was thinking about this patient is the roles that we have within anticoagulant clinic once the patient's stabilised, in terms of an outreach service for dosing anticoagulants and for giving advice to ward teams, including junior doctors who might not have as much experience of, you know, using anticoagulants in difficult situations or in different drugs. So I don't know if you want to talk a little bit about, you know, what your thoughts are about outreach and how that can support ward-based teams in these sorts of situations.
Yeah, I think that we would need quite a substantial increase in our staffing probably to be able to do something like that. So we do obviously take telephone calls numerous times really in the week from doctors asking us for our thoughts. And to be honest, I think if it's an imminent discharge, then we would prefer the low molecular weight heparin if the patient is not stable enough to be switched over, and obviously these are still early days, so by the time they actually land in our clinic, then we can be reviewing them and seeing how they're going. If we need to prescribe more enoxaparin, that's what we do, with a view to hopefully being able to switch them over to a DOAC. And we would always obviously consult our hematology consultants for further advice if we were unsure. But in the main, if the patient is stable and there's no bleeding, obviously we always take the bleeding risk into account, That's our highest priority. So if we do decide to switch the patient to oral medication, then that's one of the main part, obviously, of our safety netting would be to advise about bleeding risks and to attend ED should that happen.
I'll comment.
Yeah, and that's, sorry, go on, Will.
It's not specifically relevant to this case, but my impression is, and again, I don't know whether this is widespread, is that teams sometimes, if there's some sort of thrombotic issue that requires anticoagulation and it's a little bit complicated, they'll just stick them on low molecular heparin and chuck them out to the anticoagulant clinic and sort of say, you guys can sort out what to do with this patient. We'll just stick them on heparin, send them to you. We're not going to worry about orals or anything. We're just going to get them on heparin and send them out and you know, make it your issue, your problem. I don't know what you think about that, Sarah.
Definitely. Yeah, definitely. I'd agree on that score.
Yeah, and I think, you know, as consultant haematologists, especially in the role that Will and I have, a huge amount of our work is in liaison haematology, supporting ITU, helping medical teams to manage these sorts of complex issues. And I find that part of my work really enjoyable, actually, because you deal with lots of different specialties. You know, you have a very wide range of queries. And I think that specialty of sorts of liaison haematology, whether it's in thrombosis or not, is something that's really going to take off, you know, over the next 5 or 10 years as more and more complex patients are in hospital and these issues arise.
I mean, sort of on this subject as well, I mean, every year, I mean, in terms of the sort of older, more frail patients, we're expecting a sort of 2% plus major bleed rate per year on anticoagulants. So we get all these people on, you know, over 1 million people in the UK is now on anticoagulants. So a lot of people are going to get major bleeding. And we know that most of them probably, after a bleed, should probably go back on anticoagulants because the outcomes are probably worse if they stay off anticoagulants. So it's not as simple as saying, right, if you come in with a bleed, you're on an anticoagulant, stop the anticoagulant, end of. If it would be really simple if that was the case, but it's not. And again, I think that often the team that admit a person with a bleed who happens to be on an anticoagulant, they'll stop it because that's what you're always going to do immediately. And then they'll send them out again to us and say, we've stopped this anticoagulant, you know, restart it, sort it out, your problem. Again, I think, again, is an issue that sort of gets thrown around, and I think it's important to, this requires MDT discussions about risks and benefits of restarting. I think it's a really tricky area and it's not something we can hide from, because if you've got over 1 million people on anticoagulants and 2% of them are having bleeds per year, then this is going to be an issue we have to deal with. And unfortunately, there's not a lot of great high quality data to support what to do, other than what the data there is says you should probably restart most of them.
Yeah, I think, you know, that MDT perspective is really important in terms of operational management. Every day, our anticoagulant clinic will get these sorts of queries coming through. So we have an arrangement where one of our consultant team goes every day to go through an in-tray of pending queries. And I find that a really helpful way of knowing that I have contact with my colleagues there, and sort of knowing what's going on in terms of which patients are out there and which patients may be in and having difficulties. So I think just purely from a sort of, you know, how you organise your service, it's thinking about how you cope with these queries and how you support colleagues in dealing with them. Okay, so it's 10:02. Oh, I can just see we've got another comment through on chat. Thank you, John, that's really helpful. So for those who can see it, that comment's about use of tinzaparin for religious purposes, saying that there's been a sort of formal issuing of an acceptance of its use, and that a letter that confirms that can be provided in Arabic for patients who need it. I didn't know that, that's really useful. Okay. So a question from Joe, which we'll take. So I'll ask Sarah to start with this one, if that's okay. So what approach do we have for supporting patients who have poor adherence? How would you generally try and support someone, Sarah, who's not adherent to their anticoagulation?
Obviously talking about the risks of and the benefits, of course. Not taking anticoagulation, the huge risk of repeated clots, or if it's the fact of a patient with AF, the risk of stroke. I think often when we speak to the patients with AF, they don't actually seem to realise, a lot of them, especially when they're very elderly, that we're actually looking at stroke prevention here. They just don't understand, and I think they're overwhelmed when they are actually in ED, and there's an awful lot to take in. So they're thinking, well, the medications, and often when you tell them, they just say, oh no, it's not called that, or they'll give us a rate control beta blocker, name of a drug, and then say, oh, you mean the pink one, or you mean the orange one, and they tend to term the tablets like that, but they often don't realise what we're trying to achieve. And then when we do say that to them, then they obviously realise that when you're talking about quality of life, the importance of taking their medication, and also looking at the medications, that making it easier, I suppose, for compliance. Maybe sometimes the schools of thought, aren't there, once a day, take the medication and it's done and dusted. And for patients that we're switching from warfarin, often when they've been on warfarin for 20 odd years, they just want one a day. They want to stick to the same time, take the tablet in the evening. But then also, is it better to give them 2 tablets a day so they can take one in the morning, and then, at least they've got something in the system if it's forgotten? Do we, that's the sort of issues that we tend to come up against. And sometimes, again, they might have problems with the tablets, such as side effects, and rashes seem to be the thing of the moment with our patients.
Yeah, and I can see someone's put in chats as well, just as you were saying, at the option of a DOAC that can be taken once a day if BD is difficult. I'd agree with that. I think I've suggested that. And simple measures like use of an alarm to remember when to take your medication, and asking about why they're not compliant. Are they not compliant with all medications, or is it specifically the anticoagulant because of concerns, sometimes disproportionate concerns about bleeding, sometimes concerns about other side effects? Comments about the ability to self-test INRs for patients on warfarin. Again, I find that really useful, especially in patients who have busy lives and who are working. It's transformative sometimes, the ability to do that. So I'm aware of the time. So Sarah, I can see you've got your hand up. We'll come back to you.
Okay. Just one more point really about obviously the beauty of the DOAC's being able to use blister packs, and we spend many a time of our day contacting GPs asking for blister packs if the patient hasn't been discharged with them, to get the medication in to ensure compliance as much as possible anyway.
I do wonder whether, it's traditionally something we've done for people who are sort of more frail, haven't we, who can't necessarily remember, but I think we should probably encourage dosset boxes more commonly for everyone. Because I did say this last week in a session I did, but I've got a dosset box for my spaniel who needs some painkillers twice a day, and it really helps me to remember to give them to him. If he's limping around, I knew I've forgotten, but I find that dosset box really helpful, so I think we should use those.
Absolutely.
Okay, on that note, I think we can probably bring it to a close. So that's been really useful. Thanks very much, firstly, to Jo for inviting us to do this. It's a real pleasure for our team to do it, and then to Will and Sarah for doing this and for being such great colleagues